Thank you, Walker and Spencer. For those, I think a few medical students are here. This is a subject given to me by Venki. Like anything else, this is more like a celiac artery compression syndrome. We see this quite often in the imaging studies, but really the actual indication for treatment is very limited. So the famous saying that says that, don't treat the x-rays, treat the patient is very important for this. So Nutcracker syndrome is extensive compression of the left renal vein between supramesenteric artery and the aorta, resulting in renal vascular congestion, renal vein congestion mainly, presenting as hematuria, proteinuria, orthostatic hypotension, abdominal flank pain, or even renal dysfunction in some patients. Long-standing venous compression leads to collateral venous drainage pathways through lumbar, gonadal, and pelvic veins, which may explain symptoms and syndrome overlapping with pelvic congestion syndrome and some other symptoms that Dr. Spencer just also spoke about, her conditions. Often these two occur together. Of course, this is a diagrammatic representation, how the supramesenteric artery is compressing the left renal vein between the aorta and the supramesenteric artery. On the right side, you see the classic bird beak appearance of the dilated left renal vein being compressed by the supramesenteric artery and the aorta. The most common type is the anterior. The Nutcracker syndrome could be different types. The most common type is the anterior Nutcracker syndrome, where the left renal vein is compressed between the supramesenteric artery and the aorta. But there is also a posterior Nutcracker syndrome, which is much rarer, when the left renal vein is retroaortic in position, and so the left renal vein is compressed by the aorta against the lumbar spine. Then there is also a combined Nutcracker syndrome, where there is a circumaortic renal vein collar, which might get compressed. And there are rare causes of left renal vein compression, like severe lymphadenopathy, malignancy, severe lordosis, pregnancy, rapid weight loss, and even intestinal malrotation in children. The renal vein congestion causes, of course, obviously, increased pressure in the renal venous system. There is periureteral and peripelvic varices. They get engorged and sometimes rupture, resulting in microscopic and macroscopic hematuria. It's very important because one of the strict indications are that you need to document hematuria unilaterally. It is isolated to, of course, left-sided hematuria. Within the nephron, the venous hypertension induces a subclinical immune cascade within the vessel wall, resulting in more than normal local release of norepinephrine and angiotensin II upon standing. This exaggerated physiologic response to aberrant changes in renal hemodynamics results in orthostatic proteinuria. By the way, it is important to remember, of course, I didn't know until I looked at the literature, that orthostatic proteinuria is not uncommon in children, obviously, so that should not be taken as the main indication for operation. Severe systemic hypertension in some case of Nutcracker syndrome has been reported. So gonadal vein engorgement can progress to pelvic congestion syndrome, characterized by non-cyclic chronic pelvic pain, heaviness, dyspareunia, postcoital pain, discomfort, and of course in men, varicocele. Gonadal vein, of course, as you know, communicates directly with the ovarian venous plexus, uterine venous plexus, eventually draining to the hypogastric venous system via different routes and gluteal-perineal veins. So pelvic congestion syndrome and Nutcracker syndrome can overlap in 18% of the patients. So what are the diagnostic tools? Duplex of the left renal vein is very important. Actually, we'll go through a little bit detail what are the criteria for the duplex for us to say that it is symptomatic Nutcracker. CT venogram or MR venogram, then finally renal vein venogram, intravascular ultrasound, and cystoscopy. So all these criteria have to be met before we say that this is the Nutcracker syndrome symptomatic. The most important thing on CT or MR is the so-called aortomesenteric angle, where the angle between the supramesenteric artery and the aorta is less than 35 degrees. That should be there. Then, of course, on the cross-sectional imaging, you can see the diameter of the left renal vein at the hilum and at the most compressed portion. This diameter, the ratio should be more than 5 to qualify for symptomatic Nutcracker syndrome. And of course, finally, you go to the venogram proper. This is a normal left renal venogram. As you can see, you see a normal left renal vein, and you do not see any of the tributaries. You don't see the adrenal vein, you don't see the gonadal vein or anything like that. In contrast, in the Nutcracker syndrome, as soon as you inject the dye, you can see the reflux into the gonadal vein. This is very classic. And similarly, duplexes criteria, you can look at the velocity of the hilum, and then look at the velocity of the renal vein, peak systolic velocity we are talking about, at the compressed portion, and if the ratio is more than 5, that is considered to be diagnostic for symptomatic Nutcracker syndrome. And then further, you can also measure the pressures. You can measure the pressure in the inferior vena cava when you do the renal venogram, and in the renal vein, and if the gradient is more than 3 to 4 millimeters, that is diagnostic. So how do we manage this? Multi-specialty team is vital. You have to have the primary care physician, gynecologist, urologist, and the vascular surgeon or the interventionalist. Initial therapy is counseling, nutrition, physical therapy, and weight gain. We should never go primarily for intervention in these patients. In children, the medical management only. No intervention is recommended for children, since most of them actually become better. Surgical or interventional treatment only when persistent disabling symptoms, despite medical therapy and diagnostic criteria, are present, as we mentioned before. So what are the surgical options? Left renal vein transfer to IVC, gonadal vein transposition, gonadal vein ligation, including autotransplantation. This is the surgical vein, left renal vein transposition to IVC. This is an operation, of course, of quite a bit of magnitude. Then this is the gonadal vein transposition to the IVC. However, these are replaced now by endovascular options, which is the left renal vein stenting with or without coil embolization of the gonadal veins. This is really the treatment of choice in most patients. And you can see here the left renal vein has been stented, the angle has been enlarged, and this is now the accepted treatment, not the surgery itself. However, we do have problems with this because of there's a, IVC thrombosis, stent migration can occur. So the latest now is the laparoscopic or robotic placement of extravascular stent is the newer treatment. Left renal vein is covered by externally supported stent or a graft or a titanium extravascular stent. The latest is a 3D printed PEEK material, which stands for polyether ether ketone extravascular stent. And in fact, this is the 3D printed stent. As you can see, it can go around the left renal vein and it can automatically click into causing actually protection of the renal vein. This is the operative picture. You can see the dilated renal vein, and in the lower half, you can see how the stent can be placed. This is done either laparoscopically or robotically. This is a post-op CT scan of extravascular stenting of the left renal vein by this new PEEK material. I think that stops my talk. Thank you very much, and we'll have questions later. Thank you.
Thank you much.